Hi, everybody. This is Jody Roberts speaking to you about ACL sprains, injury prevention, and disablement model. Again, my name is Jody Roberts. I'm a licensed athletic trainer, licensed and certified athletic trainer. I work for Centralia High School, and I am currently a doctoral student at Indiana State University, obtaining my doctorate in athletic training. So there are three things that we got to kind of think about when we talk about preventing ACL injuries. And the first one is identifying the injury risk factors. So the first thing that we have are some biological risk factors. Those would include the fact that we have females that are at higher risk, people that face hormonal changes, notch width is an indicator for a risk factor, certain static positional alignments, and having a previous ACL sprain increases your risk for having a second ACL sprain. There are some environmental risk factors that come along with ACL sprains. Having abnormal lower extremity biomechanics, specifically three-dimensional knee loading in certain ways. If we were to measure knee extension movement, proximal anterior tibial shear force, knee valgus varus movement, and watch knee internal and external rotation movement, we might find some abnormalities that lead to higher risk for ACL injuries. Some lifestyle behavioral factors. Obviously, those that are active populations are at higher risk for incurring an ACL injury. Any activities that require cutting and or jumping and contact sports also increase your risk for having ACL sprains and or ruptures. All three of these things combined lead to your health-related quality of life. So if they're facing any one of these factors, they're going to have a lower, and they're aware of those factors, making them at a higher risk for having an ACL sprain. It's going to lower their health-related quality of life. They might distrust their body if they're aware that females have a higher chance of doing it. They might distrust their program if they find that their program with their activity is not doing anything to prevent ACL injuries. And they might distrust their facility depending on the risk factors that have to do with the facility environments. For example, if it's a really muddy field, they're likely to get their foot stuck, twist, turn, and cause that ACL to rupture. In the chance that there are, that a patient were to incur an ACL sprain, I did a look at elite youth soccer players and was able to break down the different features of the disablement model. So the first thing you'd find is laxity and decreased stability of the knee. You would also find increased anterior translation of the tibia during activities and some possible meniscal implications. Because the whole knee joint is actually unstable in and of itself, we might also find that there are other ligaments that are put at risk. We might also see that muscles are compensating for, and that puts all of those other structures that are compensating for that laxity during activity to be put at risk for injury to those subsequent, those secondary and tertiary disabilities. So the first thing we're going to see is they're going to have some loss of agility. When it comes to slowing, stopping, changing direction, that anterior translation of the tibia is going to be pretty evident and oftentimes felt by the patient that has a sprained ACL. They're going to see that they have decreased range of motion and obviously unable to jump. The mechanics will probably be off in both liftoff and landing phase of jumping. It would affect their participation for several different reasons, the first of which is fear of re-injury. One article stated that only 53% of patient population returned to their pre-activity levels after they incurred a reconstruction, an ACL reconstruction. There are poor health-related quality of life scores associated with secondary and tertiary pathologies. Those pathologies include osteoarthritis, meniscal lesions, and revision of if they had to do another reconstruction therapy. Some environmental factors that they might face. Some environmental factors that they might face are the societal expectations that we talk about in disablement models. We need to remember that these patients are facing expectations from their coach and their coaching staff, facing expectations from their teammates, family, friends, their athletic trainer, and even other healthcare professionals. And all of those things build that environment that patients often face. They could also have an because being an athlete is so ingrained into being a part of their life, that also makes part of their environment, and letting those people down leads to a poor health-related quality of life. Because when you have that social impairment, when you take those people away from the activity they're used to being in, it's going to lead to that lower HRQOL. It's difficult because we're unable to modify games to accommodate ACL injuries. We're able to modify rehabilitation, so it's important as healthcare professionals that we take every step that we can to modify those rehabilitation measures, so that they can still feel like they are a part of the team. Influencing those environmental factors, if that means that you are, and we'll go into this a little bit more, but talking to those people that are the support system for the athlete is a really important step that we can make. The patient might be facing their own natural fears of re-injury, of unknowing, being uneducated about what this means for their season, what this means in the timeline of them being an athlete. All of those things we also have to consider. And then, of course, we need to remember that they're a human being and that there's going to be some impairments to their activities of daily living that we need to accommodate. Are they going upstairs, up and down stairs? Is this affecting the way that they sleep? Is this affecting the way that they're able to sit in a classroom? What other areas of their life are they seeing that that their ACL damage is interrupting their life? So now let's talk about the most important part, injury prevention. So I posted the disablement model here, but I want to focus over here on the corrective exercises that we can have. So the very first thing that we need to do to prevent something is one of the first things we could do to prevent ACL ruptures is a screening measure. The screening measure that I looked over was the landing error scoring system, and relating it back to its ability to prevent ACL injuries. They found that patients that were scoring around a 5 and up were at a risk or increased risk for ACL ruptures. And if we were to identify those people, we would be able to put them through corrective exercises. However, you could take a whole team. There is an option to take a whole team through it if you identify that the entire team is put at risk, or is at risk for an ACL rupture for various reasons. You can put them the whole team entirely through a corrective exercise. So some of the exercises that we were able to identify is a proprioception program, a 5-phase program that talks about working on balance that prevents a number of injuries, but is highly correlated with preventing ACL injuries. There were also several articles that cited neuromuscular training that also engage proprioceptive things, since that's a neuromuscular function, but also increase some strength things in order to prevent ACL injuries, and identifying biomechanical and knee loading activities and strengthening those things, strengthening those mechanics and making the patients feel comfortable in doing those activities. If we do that, we erase the disablement model, and that's we erase a lot of the disablement pieces. We eliminate, obviously, the injury, a few of the environmental factors, and begin to improve their health-related quality of life. But if they do incur an ACL injury, it's important to understand the environmental accommodations that we can make. It is important that the patient is allowed to be with the team as much as possible to make them feel a part of that team and answer to that societal impairment that they are facing. It's important that all activities of daily living are accommodated. Make sure that crutch use is able to be used in all facilities that the patient's going to be in and out of throughout their day. And then last but certainly not least, going back to making goals with the patient and the coach to ensure that team participation is a thing. A lot of times when a patient becomes injured, if an athletic trainer is on top of it, they'll make goals with the patient. But making goals with both the patient and the coach will make sure that the patient feels like they are still a part of the team, that the coach still cares about their recovery, still cares that they are an integral part of that team. With that, we erase the remainder of the disablement model and are able to begin focusing on the best health, an increased health-related quality of life that we would like to see. Thank you for listening. If you have questions, you can reach out.